trauma nurse practitioners here at the University of Utah, and also a faculty member at the University of Utah College of Nursing. And he received his associate degree in nursing from Salt Lake Community College, his bachelor's degree from the University of Utah, and his master's degree in acute care nurse practitioner, and his doctorate of nursing also at the University of Utah, and has actually published on geriatric research and given talks on the elderly population. And we're going to talk about management of the older adults with traumatic brain injuries, and we'll turn the time over to Blaine. Thanks.
All right, thank you. It's a pleasure for me to be here with you today and to talk about something that I think is very pertinent in society today. We know as society in general is getting older, and we are also seeing an increase, from what I believe, an increase in older patients who are being more active. We're seeing more older patients who are skiing and riding ATVs and doing things that they didn't used to do in the past. So because of that, I believe we're also seeing more head injuries in the older adult population. And so I wanted to talk today a little bit about managing older adults with traumatic brain injuries, and specifically focus on managing older adults with traumatic brain injuries who are also taking anticoagulants such as Coumadin, as well as antiplatelets such as aspirin and Plavix. So the objectives of this presentation will be first of all to discuss the effects of aging on the brain. I'd also like to review the different types of traumatic brain injuries that can occur in older adults. We'll talk about both axonal injury as well as direct injury to the brain. And then to take a few minutes and look at some studies that have been done over the past 4 or 5 years regarding the management of traumatic brain injuries in older adults who are taking both anticoagulants and or antiplatelets. So let's begin first of all in talking a little bit about aging and the brain. And we know that over time the brain decreases in weight and size. We believe that this is the primary mechanism for this is a decrease in the number of neurons that are within the brain. And as you look at CT scans of the brain of an older adult, you'll actually see that they have a lot more space within their cranial vault that is not filled with tissue like it would be in a younger adult or in a child. Some of the structural changes that occur with aging in the brain are, first of all, like I already mentioned, a decreased brain weight, a decreased brain size. The dura mater also becomes more adherent to the skull. So as these patients fall or hit their head and suffer skull fractures, then that dura mater is more adherent and may be more likely to tear. We also see a meningeal thickening within the brain. We see an increase in the size of the subarachnoid space. And if you think about that, that would be related to the shrinking of the brain. As the brain gets smaller, then those spaces, both the subarachnoid space and the ventricles, are going to be able to enlarge somewhat because they don't have tissue around them pushing on them and making them smaller. And then with aging, we will also see vascular changes within the brain and within the basal ganglia. And all of these can play an effect on caring for these older adults, as we know that they do have more space within that cranial vault, like I mentioned, which gives them a little more room to bleed than you or I would have. There are also several cellular changes that occur with aging. The first being a change in the dendrite structure of the brain. Older patients will also have a lipofuscin deposition. And lipofuscin is a yellow-brown fatty pigment that gets deposited intracellularly within their brains. They will have neurofibrillary tangles, and we've heard a lot about these. These are what are diagnosed or what are seen on autopsy in patients who have Alzheimer's disease. So we will see an increase in these in the older adult population. We'll also see an increase in senile plaques on the brain, an increase in Lewy bodies. Lewy bodies are an interesting kind of phenomenon that is seen. Patients who are found to have Lewy bodies that have deposited on the brain tend to manifest symptoms that are a combination between Alzheimer's disease and Parkinson's disease. So they will have symptoms of both of those diseases because of these Lewy bodies. And then we will also have an alteration in neurotransmitter function within the brain itself. Yes?
What is it, the amyloid that's laid down in later life with it's associated with Alzheimer's, is that the lipofuscin or the senile or none of the above?
I'm not sure there. I think they're more of the senile plaques. I'm not exactly sure. But you do have the amyloid protein plaques or the Lewy bodies. They may actually be the same thing. I'm not exactly sure on that. Okay. So excellent question, though. So that is kind of a brief overview of what happens to our brains as we age. So let's begin to talk now a little bit about traumatic brain injuries. We'll spend some time talking about the different types of brain injuries. And then, as I mentioned previously, we'll talk about treatment and the treatment and management of patients who have these injuries. So first of all, I'd just like to define what a traumatic brain injury is. This is from the National Head Injury Foundation. A traumatic brain injury is a traumatic insult to the brain capable of producing physical, intellectual, emotional, social, and vocational changes. We know that there are approximately 2 million total head injuries that occur each year in the United States. Of these, about 1.6 million are mild and don't require hospitalization. So this is pretty common. We'll see football players taking a shot to the head, or soccer players, or baseball players, or people hitting their head that may get not necessarily knocked unconscious, but stunned a little bit. They are doing better, they're taken out of the game, and they're never taken to the hospital for these injuries. I think we're seeing more and more, though, that in these populations we're being a lot more careful in treating head injuries. We know that people like Steve Young had multiple concussions, and we're seeing now that they're being a lot more careful in not sending these people back to play immediately, but giving them time to recover. When I talk to patients who have had even mild concussions, we see a lot of skiers who get those. I recommend that they don't ski for a couple months so that they're not stacking concussions on top of each other. Of these 2 million head injuries, approximately 500,000 will require hospitalization. 450,000 of these are admitted to the hospital alive. Approximately 80% of these have a mild traumatic brain injury. 10% have a moderate traumatic brain injury, and another 10% have severe traumatic brain injury. So these are the populations that we're seeing either as EMS, who you're seeing them in the field and transporting them to the hospital, or they're being seen in the emergency department and throughout the hospital. In order to understand the effects of head injuries on the brain, we need to have a good understanding of the Monro-Kellie doctrine. And I always ask my students if they've ever heard of the Monro-Kellie doctrine, and they tend to think back to history and think about the year 1776 and wondering if this is something to do with the Constitution. But it's not. It's a doctrine that has to do with our brains. Basically, the Monro-Kellie doctrine states that the volume of the intracranial contents needs to remain constant. So within our intracranial contents, we have cerebral spinal fluid, we have blood, and we also have brain tissue. And if you think about the brain, think of it like a solid box, a wooden box of some type. that you can put stuff in that box, but if you overfill the box isn't going to expand to take on the extra contents within the box. And the brain is the same way. If our brain begins to swell, if our brain has more blood going to the area, or in some cases if we have cerebral spinal fluid that's being trapped in the brain because of the inability to drain, our skull can't just expand to allow that to not cause a problem. And what will happen is one of these contents increases, then another one of the contents is going to need to decrease. Initially, we'll see some of the cerebral spinal fluid that will leave the cranial vault itself and will begin to go down into the spinal cord, or that area. But that can only hold so much itself. So as our brain has an injury and our brain begins to swell or we get blood in the brain, the only place for that brain tissue to go is out the bottom of the skull, and that's what we consider herniation. So in everything that we do in treating traumatic brain injury, our goal is to prevent that herniation from occurring. We want to make sure that there's adequate room within that cranial vault for the tissue, blood, and the cerebral spinal fluid to coexist without this causing significant problems to the patient. Now, you may be asking, what can we do about this in the field? Once a patient gets into the hospital and they may be seen by a neurosurgeon or by an ER physician or another trauma physician, and there are a lot of things that can be done here. They'll put drains in an attempt to relieve some of the pressure. They may actually do craniectomies and remove part of the skull to allow that brain to swell. They'll use different medications. They'll sedate them, and all in an attempt to prevent the swelling within that area. In the field, though, you're somewhat more limited. You can't just take out a saw or, like they did in MASH, take out a pen and do surgery in the field on the skull and the brain. So some of the things that have been looked at for many years, they've talked about the role of hyperventilation in an attempt to try to keep the brain from swelling. This would be a short-term fix, and you would need to be discussing this with the emergency rooms if possible as you're transporting these patients. Some people are using 3% saline in an attempt to keep the brain from swelling. And then there's our typical things that we've done in the past, and that's the use of mannitol in an attempt to prevent swelling of the brain and trying to prevent herniation while in the field. We know, however, though, that with severe brain injuries there may be not a lot that you can do, and that many of these severe brain injuries may actually die at the scene. Here's a slide of something that is probably or something that you've seen many times. You may use this on a daily basis. I know that hospital providers caring for patients with traumatic brain injuries use this multiple times a day. And this is our Glasgow coma score. And we'll see in a few minutes how this Glasgow coma score is used to help us identify how severe the brain injury may be as we begin to evaluate these patients. The Glasgow coma score is divided up into 3 categories. Remember that with the Glasgow coma score, the lowest score that you can receive is a 3. So you never get a 0 for these categories. The only thing that may be different there is under verbal response. If they are intubated, then you would add a T to your score. And so if a patient who is completely non-responsive that is intubated would be an 11T. Excuse me, a 3T. 1 for eye-opening, 1 T for verbal response, and 1 for motor response. A patient who is completely with it and is responding appropriately, excuse me, but is intubated, that would be the person that would have an 11T. So in looking at the Glasgow coma scale and traumatic brain injuries, These have been classified as mild TBIs, moderate TBIs, or severe TBIs, depending on their Glasgow Coma score. It's important to realize, though, that this is a Glasgow Coma score when they're not sedated and not chemically paralyzed. You can't adequately assess it if they are sedated and paralyzed. So this is what their score would be without medications on board. So a mild TBI, or what we'd consider a mild concussion, would be a Glasgow Coma score of somewhere between 13 and 15. 15 being the highest score that you can obtain with a Glasgow Coma score. A moderate traumatic brain injury would be a Glasgow Coma score of 9 to 12. With a patient of a GCS of 9 to 12, you want to suspect some structural injury, such as hemorrhage or some type of contusion of the brain. And then a severe traumatic brain injury is a Glasgow Coma score between 3 and 8. And this is associated with cognitive and or physical disability or death. So this is a quick test that you can do as you initially see these patients in an attempt to determine how severe their injury may be. Now we'll see later in the presentation that there's been some studies done on older adults who are taking antiplatelets or anticoagulants who have a GCS of 15 upon admission, but they still have clinical signs of brain injury on CT scan. So that's important to realize as you're in the field, that if an older adult taking these medications has hit their head, just because they have a GCS of 15 doesn't mean that they're totally okay and that they will be fine in 4 or 5 hours. And we'll talk about that a little more as we go throughout the presentation. So let's talk now about some different classifications of head injuries. First of all, we have what we would consider a closed head injury. A closed head injury would involve striking the head against a hard surface or a rapidly moving object striking the head. In a closed head injury, the dura mater remains intact. So that's that will help us in this definition of what's a closed head injury. This may cause both focal brain injuries. A focal brain injury is an injury to a specific part of the brain. So if you get hit with a baseball bat and that part of the brain that's bruised is a focal injury. These may also be diffuse axonal injuries. And diffuse injuries and diffuse axonal injuries are where you get a tearing of the neurons a tearing of the axons within the brain.
So focal injuries are, you have problems with vision, speech, and those things, balance.
Right. Yeah, so he just stated that focal injuries, you would have problems with vision, speech, balance. Basically, it will affect whatever part of the brain is injured. So if you've hit a motor area of the brain, you'll have motor defects. If you hit a speech area of the brain, you'll have speech defects. It would be similar to a stroke in that. And then the diffuse axonal injury, which we'll talk about more later, is more diffuse injury to the brain, and it's much more difficult to recover from severe diffuse axonal injury. They have poor recovery. The second type of injury that a person can sustain is an open head trauma or an open brain injury. And this is basically, the definition of this is where the cranial contents become open to the environment. This picture is a pretty dramatic open injury, being impaled through the face and the skull and into the brain. Actually looks like down into the spinal cord. But those patients who have skull fractures, your basilar skull fracture or any skull fracture, especially with a laceration over that or near that area, would be considered having an open brain injury. And these are important to note because these patients are at an increased risk for developing infections in that area and developing problems like meningitis. I remember taking care of a patient many years ago who had a head injury and complained of severe headaches within a day or two of that injury. And we felt that it was likely just related to hitting his head. But in reality, the patient had actually developed a meningitis And this patient was initially sent home with the belief that these headaches were related to hitting his head, came back to the emergency department the next day and was diagnosed with meningitis. So it's important to realize that these patients are at an increased risk of infection, and don't just chalk everything up to, oh, they hit their head and that's why they have a headache, especially if the headache is severe and unremitting, which this patient's was. He ended up being treated and going on and doing okay, but it just brought home the point of we do need to look at other things in addition to just, oh, they just hit their head. So that would be an open head trauma. Now, with both the open and the closed head injuries, we can have different injuries or different focal injuries that we'll talk about to the brain. So the first one is a contusion. A contusion is just a fancy word for a bruise of the brain. So I remember in high school, I was a big kid, and I wasn't real aggressive. I wasn't into fighting, and occasionally someone would just walk up and punch me in the shoulder because they knew I wasn't going to take him on and fight him in the halls. And I would get a big bruise on my shoulder when I'd get hit. A contusion of the brain is the exact same thing. The brain gets hit for some reason, has a force applied to it. There's a bleeding that occurs to that area because of small tears in the blood vessels. And of note, the smaller the area that's impacted, sometimes you'll have a greater injury to that area because the more force is applied to a smaller area. So if you think of a patient, say, hitting their head on the wall versus someone hitting them really hard with a baseball bat, that small area of force that's actually greater force from that baseball bat may cause more injuries than bumping their head on the wall. Contusions are more commonly seen in the frontal lobes, and the maximum effects of injury related to contusions, i.e. bleeding and edema, peak at about 18 to 36 hours after the injury. And if you think about that as other parts of the body, that's pretty similar. We know that when we sprain an ankle, we're 36 to 72 hours out before the maximal swelling occurs. It's going to be the same thing with the brain, maybe a little shorter time frame, but up to about 36 hours is where we'll see the majority of, or the extent of the injury. Along with brain contusions, we can have Coup and Contrecoup injuries. And this is where I think this picture shows it well. This person is hit in the frontal lobe with a baseball bat, which applies enough force to usually jerk that head back, cause that brain to move within the intracranial contents, or within the intracranial vault, and hit the back of the skull. And in these patients, they'll have an injury both where the primary impact occurred as well as where the secondary impact occurred. So you may see injuries in different areas of the brain depending on where that impact occurs. Also with diffuse axonal injury, we'll talk about this again in a little while, may have injuries throughout the brain, thus the word diffuse, because of the shearing and tearing in multiple areas within the brain. So those are contusions. The next thing that is pretty common to see are epidural hematomas. Remember that epidural means above the dura, and above the dura we have more small arteries in that area. So epidural hematomas tend to be more arterial in nature, and thus they become medical emergencies because of the bleeding that occurs from these small arteries rather than an oozing from veins. The typical kind of classic presentation that we see with epidural hematomas are the patient hits their head or gets hit in the head, they get knocked out, they come to, and they're doing okay. And then over the next little while, they begin to have a change in their level of consciousness again. They begin to get more confused, or they begin to lose consciousness. And this occurs because this bleeding is occurring rapidly and these patients will eventually end up losing consciousness totally if it's severe enough. And as we talked about with the Monro-Kellie doctrine, as that blood increases in the brain, within the brain and around the brain, then the contents of that cranial vault are going to have to go somewhere else, and they will begin to herniate down through the bottom. And so epidural hematomas in many cases are considered a medical emergency, and they're taken emergently to the operating room, and the epidural is evacuated by a neurosurgeon. Now on CT scan, these epidural hematomas have a kind of a classic shape. They have more of a lens shape. So as you look at a CT of an epidural hematoma, they'll look like these in the picture here, where it's lens-shaped in nature. And in a minute, I'll show you what a subdural hematoma looks like, which is a different shape and more layered out.
They usually have their pupil on the opposite side of the injury that has problems with the axon dilation.
Right. So Russ just stated that as you have an injury, if it's severe enough, that the opposite pupil you'd have the problem with dilation on the opposite side, depending on where it occurs around the brain. But yeah, so it would be if the severe injury is on the left, you may see pupil dilation on the right in these patients. Good point. The next one is a subdural hematoma, and that is exactly what it says, which means this bleeding occurs below the dura of the brain. These tend to be venous in nature, so our epidurals are arterial, subdurals are more venous. They're more bridging veins that tear in this area and cause this continual oozing of blood to the area. There are patients that may also develop subacute subdural hemorrhages, and we see these in older adults, and where they will start having problems, and then within a couple weeks they're having more and more problems. They come to the emergency department, a CT scan is done, and they're found to have a pretty significant subdural hematoma that's developed over time. And so these are not always traumatic in nature, but they can occur in older adults.
And the outcomes are not very good in the older adults.
Right. Right. So an older adult with subdural hemorrhage that's gone on for time, Russ said that their outcomes aren't very favorable, which is very true. So the reason that they're not manifested initially is, as we talked about at the beginning of the presentation, is they have a lot more room within the cranial vault to actually bleed because that brain has shrunk in size, and they'll put more blood into the area before they begin to have symptoms. As the subdural hematoma expands, these patients will also develop an increase in their intracranial pressures. As intracranial pressure increases, the perfusion to the brain, or what we call the cerebral perfusion pressure, decreases, and you begin to have a difficult time in providing the brain the oxygen and nutrients that it needs to stay alive. Here's a picture of a subdural hematoma. As you notice on this, it will show up as a more white area around the brain, and these will tend to layer out more because they're below that dura. They're below that area that's actually attached to the skull itself. So we'll see these layering out through the brain. And that's the difference as you look at CT scans of what they will look like and different things that they look like. So we can also have intracerebral hematomas, which means this would be like a really bad bruising where you get significant bleeding within the brain tissue itself. These may occur, or delayed intracerebral hematomas may appear 3 to 10 days after the head injury occurs. So these also, once again, don't necessarily appear immediately, but may occur later. And that's why it's important that we keep a close eye on on these patients, especially patients who are on anticoagulants and antiplatelets, because some of these things can develop later, and we want to make sure that we've watched them long enough to know that something isn't beginning to develop before we send them home from the emergency department. The next type of injury that can be seen is what we call a subarachnoid hemorrhage. These commonly are non-traumatic in nature. These are the bleeds that we commonly see in older adults who begin to have bleeding within the brain in the subarachnoid areas. They develop over time, and then they're brought to the hospital a week or two after the development of the bleeding. And as Russ said, they don't have a good outcomes following these injuries. So another thing that these tend to occur because of a rupture of Barry aneurysms or arteriovenous malformations within the brain. They can, however, occur because of traumatic injury also. So it's important to know that they exist. One thing about these is they may be difficult to see initially on a head CT. So if you have a patient who has the beginning of a subarachnoid hemorrhage, your initial CT scan may not show very much, or it may be very subtle with the development of these subarachnoid hemorrhages. So these are an injury that are easy to miss just because of the subtlety of their initial presentation. The next injury is intraventricular hemorrhage, which means that you get bleeding into the ventricles within the brain. And remember that these ventricles normally have cerebral spinal fluid in them, so if we're getting more blood within the ventricles, it may cause blockages of the CSF or a decrease in the CSF to the area. So this is another thing that you want to be aware of as you see these patients. So those are our focal brain injuries that we've just talked about. Let's talk now about what we consider diffuse brain injuries. These are things like concussions and axonal injury. So many times this is what we're going to see in our young athletes who are hitting their head. The head CT is normal, but they've lost consciousness or been confused, and these are diffuse brain injuries. So the first one is a mild concussion. We can have a classic concussion, and as I will go through the definition of each of these so you'll see what they mean. We can have mild diffuse axonal injury, moderate diffuse axonal injury, as well as severe diffuse axonal injury. The first one that we'll look at is a mild concussion. These can be graded as grades 1, 2, and 3. A grade 1 mild concussion is the patient who has hits their head, has some confusion and disorientation accompanied by momentary amnesia. So we tend to call it, they had their bell rung, basically. They don't necessarily lose consciousness, but they do become a little confused and disoriented, and then they clear within a short amount of time. A grade 2 is where we have momentary confusion with what we call retrograde amnesia, and this develops after 5 to 10 minutes. So they don't really remember what was going on previous to that injury. And commonly we'll see skiers who will come in and continually ask, why am I here? What did I do? And they'll ask that over and over and over again because they don't remember what happened to them. All they know is that they're in the present, they're in a hospital, and they don't know what's gone on before. Memory loss in these people usually involves, as I already stated, it can occur several minutes before the injury. So they may know that they were skiing, or they may know that they were riding their bikes, or that they were walking up the stairs, but they don't know much that was going on before that. Grade 3 is confusion and retrograde amnesia that's present from impact. So these patients immediately are confused, and they may also, so this is a little more severe, and they're confused initially, and this may continue on for a little while. So those are our mild concussions. We have what we call the classic cerebral concussion. This is immediate loss of consciousness after hitting your head that lasts for up to approximately 6 hours. These patients will have both retrograde and anterograde amnesia, so they will forget what went on both before and after their injury. And these are usually associated with pathological findings, which means that you may do a CT of the brain and you may see a focal injury in these people. We have what we call uncomplicated classical cerebral concussions. This is where no focal injury is noted. And then complicated classical cerebral concussions where, as I mentioned, you can do a CT and see an injury that's occurred. The next kind of level of injury is mild diffuse axonal injury. This is the patient who hits their head or has a shearing force of some type that causes the axons to shear or tear within the brain. And if you don't have a lot of them torn, then that's what we consider a mild diffuse axonal injury. The post-traumatic coma lasts for somewhere between 6 and 24 hours. These patients, however, may have residual cognitive, psychologic, and sensory motor defects following this type of an injury. Moderate diffuse axonal injury. Coma lasts more than 24 hours. These are commonly associated with basilar skull fractures as well as other focal injuries. And recovery in these patients is often incomplete. If it's a moderate injury, they may go back to living their life in a somewhat normal manner, but will have defects that they will notice throughout their life. And a lot of times it's the family that notices it or the friends. It's not the patient themselves, because they don't always realize what's gone on. And the wife will bring it up, or the daughter, or Russ.
And the basal skulls, a lot of times, you won't see it initially, but you'll see that little bluing behind the ear.
Right. So that's a good point. Russ said that with the basilar skull fractures, you may not see it initially, but eventually you may see what we call raccoon eyes and battle scars, which is bruising behind the ears, or bluish-looking skin behind the ears, or a raccoon-looking face with what looks like 2 black eyes, or a black eye. The next one is severe diffuse axonal injury. This is because of a severe mechanical disruption of axons in both hemispheres. These may also affect the diencephalon and the brainstem. Severe diffuse axonal injury is a horrible injury. These patients are kind of the patients that we think of that they may survive, and if they do, they may be chronically ventilated and in a vegetative state for many, many years. So this is a bad injury for these people. So now that we've looked at the different types of injuries, we've talked a little bit about aging of the brain. Let's look at some studies that have been done which address the management of older adults who have a traumatic brain injury and are taking antiplatelet or anticoagulant agents. I think this is a very important thing to be aware of. As our population gets older, we tend to see a lot more patients on Coumadin, on Plavix, and on aspirin or other anticoagulants or antiplatelets. It almost seems to be commonplace that everybody over 65 is on one of these. If not younger, many of us will take an aspirin a day in an attempt to prevent heart problems, but in actuality it may cause a problem if we do hit our head and cause more bleeding. Generally, trauma in the elderly, they have higher short and long-term mortality rates. They typically require a longer ICU stay and an overall length of hospitalization. They have a higher pre-hospitalization mortality rate. So these patients are more likely to die at the scene or prior to getting to the hospital if they have a severe injury than is your young child or your young healthy adult. They also have a greater relative decline in functional status. And if you think about it, some of our older adults who are failing already, and then they end up having a traumatic event, and it will just increase the rate of their functional status decline. So let's look at some different studies. This first study looked at patients in the emergency department who had a GCS of 15 upon admission. And I think many times we feel like if they have an initial GCS of 15, that they're probably just fine. This study did give some results, though, that would cause us to rethink that a little bit. The purpose of the study was to determine the frequency of intracranial hemorrhage in patients taking warfarin or clopidogrel, which is Plavix, who had a GCS of 15 upon admission. They looked at 141 different patients. They had a mean age of 79, so they were actually quite old. And the results were interesting. They found that 43% of patients with a documented loss of consciousness had a positive CT result. So they were, when they got to the ED, they were totally fine, but they did have a reported loss of consciousness before. And that's a pretty good number if you think almost 50% of these older adults who are taking these medications who hit their head, get stunned, get knocked out, come to, are totally normal when you see them. But almost half of these patients had a positive CT result, which means that they saw something on their CT scan indicative of bleeding. This next one I thought was also very interesting. 18% of patients without a documented loss of consciousness also had positive CT results. So that's almost 1/5 of the patients who are taking these medications, hit their head, never get knocked out, but when they do a CT scan, they find that they do have bleeding. And my guess is that this bleeding would show up later. These may be our subdural patients who have waited for 2 weeks as their headaches got worse and worse and worse, and then their daughter realizes they're more confused, brings them in, and they've actually been oozing over time.
That's actually amazing. It would be 61%.
Yeah, yeah.
The population that comes in that's on warfarin and has some type of head injury.
Mm-hmm.
Positive bleed.
Yeah. So Russ said that it's amazing that 61% of patients on these medications who hit their head were found to have some type of head injury that could actually be seen on CT scan. So that's a scary thing when you think about it. 26% of patients with external signs of injury above the clavicles also had a positive CT result. All right, so the next one, oh, there we go. The next study looks at the impact of pre-injury antiplatelet and anticoagulant pharmacology or pharmacotherapy on the outcomes in elderly patients with hemorrhagic brain injury. So the purpose of this study was to determine whether pre-injury clopidogrel, aspirin, or warfarin adversely affected outcomes after blunt hemorrhagic brain injury in patients aged 50 years and older. So this would apply to many of us right now. This study looked at 416 patients who suffered some type of a blunt hemorrhagic brain injury. So these patients were known to have bleeding when they were evaluated. The results were that they found mortality was significantly higher in older adults. So as they compared those over 50 to those under the age of 50, those over 50 had a higher mortality. The patients with pre-injury warfarin use had the highest mortality rate. So if you were an older adult taking taking warfarin, then you had the highest mortality rate in these patients. And their mortality rate was approximately 34%. So about a third of those patients actually died. They also found that the mortality rate was higher in those receiving platelets. And I think this can be a little confusing in that usually those patients who receive platelets are those patients who are sicker already. And so that may not tell us a lot about the advantages of using platelets or not using platelets, because these patients were probably sicker to begin with, and that's why they received platelets. The next study was, does platelet administration affect mortality in elderly head-injured patients taking antiplatelet medications? So the purpose of this study was to determine whether platelet transfusion for patients with traumatic brain injuries taking antiplatelet agents reduced mortality. They looked at 328 patients over the age of 50 who were taking antiplatelets, these either being aspirin or Plavix, with identified TBIs. They found that the transfusion of platelets in this population did not reduce mortality, but patients taking warfarin in addition to these antiplatelet agents had a higher mortality rate, which makes sense. If you're taking both an anticoagulant and an antiplatelet, you would expect that your mortality rate would be higher. And I don't know the severity of the patients that were given platelets in this study. So once again, it may be related to these patients were going to do poorly anyway, and so the platelets didn't play a big effect in caring for them. This next slide is interesting. This is a study that was done on brain injury in the elderly on anticoagulation once again. And they found that therapeutic anticoagulation with warfarin, rather than warfarin use itself, is associated with adverse outcomes after traumatic brain injury in elderly patients. So what this study, in layman terms, said is it's not just that you're taking warfarin that gives you a higher risk. It's that you have a higher risk if you're taking warfarin and you're actually in a therapeutic or supratherapeutic range. Now, the question that I ask is, why would you be taking warfarin if you're not going to be in a therapeutic range anyway? So, but once again, it's important in these patients to know that any patient who's taking warfarin, we need to find out where they are in terms of their therapeutic range as we begin to treat them. In terms of those of you who are seeing patients in the field, EMS, what this means to me is if you are called to a home to see a patient who's hit their head and they appear to be doing okay, but they are on warfarin, that it is probably a good idea to transport them and have them further evaluated rather than just thinking that they'll be okay just because they have a GCS of 15. And as that previous study showed, over 40% of patients, or excuse me, many patients who had a GCS of 15 also had head bleeds. So this next study looks at brain injury and anticoagulation once again. Their results were that all patients on warfarin should have an INR drawn. All supratherapeutically anticoagulated patients, as well as any anticoagulated patient with a traumatic CT abnormality, should be admitted for careful neurologic evaluation. And that makes common sense. If they're on warfarin and you see something on their head CT, you probably don't want to send them home. Now, they did also recommend repeating a CT scan in 12 hours post-admission and with any neurologic change. So what I take from this is if a patient comes in, hits their head, maybe initially they're okay, their CT scan is okay, but they are taking warfarin or an antiplatelet agent, it's probably a good idea to keep them around for about 12 hours at least, repeat their CT scan, and determine if any bleeding has begun at that time. So these are patients that we don't want to miss, and have it continuing on bleeding at home because we sent them home too early. This last study, they found that a rapid confirmation of an intracranial hemorrhage with an expedited head CT scan combined with prompt reversal of warfarin with fresh frozen plasma decreased the intracranial hemorrhage progression and reduced mortality. So if you do have a patient that you find that does have a significant bleed, they're on warfarin, then it's probably not a bad idea to give them some FFP and attempt to reduce that INR and help to reduce the progression and mortality of these patients. So these are the different studies that I looked at. I'd like to take just a couple minutes and talk about, from what I've seen in researching this topic and in treating patients with this topic, as some of the take-home points. The first take-home point for me, especially for EMS as well as the emergency department, is to make sure that you get a good history. Find out when you initially see that patient, if at all possible, are they taking antiplatelets and or anticoagulants. Some of them may not be taking the antiplatelets prescribed, but they may be taking an aspirin every day. And so you may want to ask them specifically, do you take aspirin? Whether it's over the counter or not, it's going to have the same effects. Do you take Plavix? Are you on any type of anticoagulant? Other tips that will let you know that they are is maybe they've had previous strokes, maybe they have a history of atrial fibrillation or cardiac abnormalities, maybe they've had stents placed for cardiac problems, maybe they've had open heart surgery, maybe they have a history of blood clots. So these are things that you can ask the patient to find out if they have any of these or have had any of these problems, and then further explore and determine if they are taking these medications. The second take-home point that I get from this is to draw an INR on all patients taking warfarin. So anybody who is seen, who's hit their head, who has any type of suspected head injury and is taking warfarin or other anticoagulants, it will do well to get an INR or to get a PT, PTT, depending on what the medication may be. But find out where they are in terms of therapeutic levels on their medications. The next take-home point that I see is that any patient who is seen in the field who has had any type of a head injury, especially older adults, and they're taking antiplatelets or anticoagulants, that it would probably be a good idea to transport them to the emergency department where they can be watched more closely rather than just because they manifest with a GCS of 15 rather than leaving them home. So this, I don't know what the protocols are in EMS across the country about transporting these patients with a GCS of 15, but it could be something to consider as you're looking at caring for these patients. The final take-home point that I see is don't be in a big hurry to send these patients home. And I know that emergency rooms are packed to the gills many times. You are dealing with so many different patients at one time. But it's important that in these patients that are at a high risk, who have suspected or known head injuries, that initial CT scan be done, determine if you see anything, and then it's probably a good idea to do a repeat CT scan in 12 to 24 hours. Now, I would say that this needs to be done in consultation with a neurologist or a neurosurgeon if you have any concerns about what to do there. But in general, I would make sure you keep them in the ED long enough to know that nothing is going on prior to sending them home. I just want to say that it's been a pleasure for me to do this presentation, and thank you for your time, and thank you for coming and listening. Thank you. yeah.
And they'll have irregular breathing patterns.
Mm-hmm.
Those wacky breathing patterns.